Gentle ventilation in neonates.
Overview. We'll be going through ventilator-induced lung injury, the pathogenesis and effects, gentle ventilation strategies, including the open lung strategy, synchronization, volume-targeted and high-frequency ventilation, followed by optimizing ventilator support. Although a crucial part of preventing ventilator-induced lung injury, we shall not be covering non-invasive modes of ventilation here. Requirement of ventilation gestation-wise. According to the Australian and New Zealand Neonatal Network data involving 19,000 infants from 25 to 32 weeks gestation, they found that the requirement of intubation and mechanical ventilation was up to 90% at 25 weeks gestation, along with a rate of CPAP failure of 50%, which gradually reduced thereafter. With the improving survival of extremely low gestational age neonates with increasing use of antenatal corticosteroids and postnatal surfactant, ventilator-induced lung injury has become an even bigger problem. Pathogenesis of ventilator-induced lung injury. There are three main driver mechanisms, including volutrauma, atelectrauma, and oxygen toxicity. Volutrauma is defined by a high-end inspiratory lung volume, most commonly seen with high tidal volumes, however, can even be seen in the presence of low tidal volumes due to regional overdistension in heterogeneous lung disease, or if superimposed on a high-end expiratory lung volume. Atelectrauma, defined by a low-end expiratory lung volume, causes trauma through repetitive opening and collapse, that is recruitment and de-recruitment injury of alveoli, as well as contributing to injury in other areas by causing regional overdistension. Oxygen toxicity, in which oxygen-derived free radicals cause cellular cytotoxicity due to high FiO2s, and even more premature infants are at higher risk due to impaired antioxidant mechanisms. Rheotrauma, defined by inappropriate gas flows, both excessive gas flow leading to flow turbulence and overdistension, as well as inadequate gas flows leading to air hunger and increased work of breathing, can be harmful. Biotrauma, defined by inflammation, the production of cytokines by pulmonary alveolar macrophages, as well as the migration of neutrophils, further leading and compounding the oxidative stress, and further on aggravated by the presence of infection. It does not occur alone but is an end result of volutrauma, atelectrauma, and oxygen toxicity. Heterogeneity during ventilation. So any lung disease causes heterogeneous lung due to both the effects of gravity as well as regional differences in disease pathogenesis. So we typically see three zones of lung. Zone 1, the healthy zone, in which alveoli remain open both during inspiration as well as expiration. Zone 2, the recruitable part of the lung, in which alveoli, though open during inspiration, are collapsed during expiration. And zone 3, which remains collapsed throughout the respiratory cycle. When we think of respiratory distress syndrome, as seen in this two-dimensional chest X-ray, we typically think of it as a homogeneous lung disease. However, when we see the three-dimensional picture here on this cross-sectional CT film, we can actually see the three different zones. Zone 1, the anterior non-dependent portion, which remains open, experiences volutrauma and overdistension due to the preferential entry of all the tidal volume here. Zone 2, the transition zone between Zone 1 and Zone 3, experiences atelectrauma due to repetitive opening and collapse, shearing forces during recruitment and de-recruitment injury. And Zone 3, the dependent and posterior part of the lung, which remains collapsed due to surfactant inactivation, actually contributes to trauma in Zone 1 and Zone 2. So here we can see the coexistence of atelectrauma and volutrauma. Volutrauma versus barotrauma, which is more harmful? So in a study on by Hernandez et al. Conducted on preterm rabbits who were incubated and mechanically ventilated on birth. They divided them into two groups. So group 1 was with a closed chest, that is, the increments in pressures were allowed to translate into increasing lung volumes through expansion of the chest. And group 2, they applied a body cast to the outer aspect of the chest to prevent lung expansion. And they found that only the group in which the lungs were allowed to expand with volume experienced lung injury, as evidenced by this capillary filtration coefficient, and hence excessive pressure alone without concomitant increase in tidal volume is not harmful. In other words, volutrauma is the main driver of ventilator-induced lung injury. Vicious cycle of ventilator-induced lung injury. So mechanical ventilation, as we have seen, leads to volutrauma and atelectasis trauma, in turn leading to biotrauma, which leads to ventilator-associated or ventilator-induced lung injury, which leads to pulmonary as well as systemic inflammatory response. The pulmonary inflammatory response leads to lung edema, non-homogeneous lung aeration, in turn leading to volutrauma and atelectasis trauma. And the systemic inflammatory response can worsen the ductus arteriosus shunt, multi-organ dysfunction, hemodynamic instability, which in turn compromise lung perfusion and gas exchange, in turn leading to increased ventilator support. And this is how the vicious cycle of ventilator-induced lung injury perpetuates itself. As we will be seeing in the further slides, excessive tidal volume exacerbates, and positive end expiratory pressure can mitigate this cycle. Ventilator-induced lung injury more often than not occurs during this critical stage of alveolar development, the saccular stage, at which viable premature birth is possible, characterized by inadequate lung functions and increasing needs of ventilator support due to surfactant deficiency, premature lung structure with a compliant chest wall. In turn, due to their premature antioxidant system, preterm neonates are at higher risk of lung injury due to ventilation per se. This leads to an inhibition of alveolarization, leading to chronic lung disease, which in turn is affected by intrauterine cytokine exposure, insufficient nutrition, lung systemic infections, as well as can be modified by glucocorticoid treatment antenatally and postnatally. This, this chronic lung disease is bronchopulmonary dysplasia, which is characterized by an imbalance between lung injury and repair in the developing lung. The global incidence varies between 10 to 89%, inversely proportional to gestation. Overall incidence being 48 to 60% in infants less than 28 weeks gestation, with a mortality of 1.5%. And we have seen a change in phenotype from old BPD, which is characterized predominantly by fibrotic changes within the lung and pulmonary vasculature, to new BPD, which is characterized by inhibition of alveolar development, alveolar simplification, and an immature pulmonary vascular system, again with the improving survival of extremely low gestational age neonates. BPD-related morbidities are many-fold with long-term effects. The respiratory system, there is up to 40 to 60% requirement of rehospitalization with LRTI within the first 2 years. Airway obstruction persisting until adolescence in up to 68%, which is fixed in 24%, and exercise intolerance in up to 60%. Cardiovascular system, the incidence of pulmonary arterial hypertension is up to 37%, and there are neurocognitive outcomes as well, as such as low IQ in 20% versus 11% in VLBWs and 3% in term. Now that we have seen the pathogenesis of ventilator-induced lung injury and its impact, let's move on to lung protective ventilation. Gentle ventilation aims to optimize adequate gas exchange and oxygenation with minimal adverse effects. Optimization and individualization of ventilation is key The principles of lung protective ventilation are derived through the prevention of the three main driver mechanisms. Firstly, we must reverse atelectasis by optimizing the functional residual capacity. That is, we must open the lung through alveolar recruitment and keep it open through alveolar stabilization, also known as the open lung strategy, hence preventing atelectrauma. Following which we must deliver an optimal tidal volume throughout the lungs, hence preventing volutrauma. And this in turn will lead to improved oxygenation and reduced FiO2 requirement, and hence preventing oxygen toxicity. So let's go step by step. Firstly, reducing atelectrauma, the open lung strategy. This strategy consists of two steps. Firstly, alveolar recruitment through application of initial high peak inflation pressures, followed by alveolar stabilization through optimal positive end expiratory pressures. When we see the pressure and volume relationship of a single alveolus from its collapse state, as we gradually increase the inflation pressures, we arrive at a critical pressure, the opening pressure at which the alveolus pops open. Following which, as we decrease the pressures gradually, we arrive at a critical pressure, the closing pressure, below which the alveolus collapses. The Laplace law states that the pressure required to keep a spherical structure open equals twice the surface tension divided by the radius. So the major force that we are working against here is surface tension. And this pressure-volume relationship is affected by compliance of the system. From the Laplace law, we can understand why the opening pressure is greater than the closing pressure. Now, coming to the PV relationship of the whole lung, which can be derived by a cumulative summation of those of its individual alveoli, each with a different compliance. We see that initially we start at the residual volume of the lungs. As we gradually increase the pressure, there is a lower inflection point above which alveolar recruitment occurs. Alveolar recruitment occurs throughout this inflation limb and is not just limited to this lower inflection point. Above a certain limit, the upper inflection point, in further increments in pressure are not leading to an increase in volume as the total lung volume is reached. And this is the zone of overdistension in volutrauma. As we move to the deflation limb of the lung, we see through the law of Laplace that hysteresis is operating here due to the presence of surface tension. And hence, at lower pressures, the corresponding volumes of the lung during the deflation limb are correspondingly higher. Further, as we deflate the lung, we again come across the critical closing pressure below which the lungs collapse. So it follows that for alveolar recruitment, the initial high peak inflation pressures will have to be greater than this lower inflection point, and yet not great enough to cause overdistension and volutrauma. And the subsequent positive end expiratory pressures will have to be above the closing pressure of the lung. The open lung strategy actually starts antenatally with the prevention of preterm birth through quality antenatal care as well as the use of antenatal corticosteroids. At birth, strategies include the early use of CPAP, selective surfactant administration, sustained inflation, whose role we shall be seeing, and volume-targeted resuscitation. And in the NICU, again, alveolar recruitment and stabilization by the application of adequate positive end expiratory pressures are crucial. The role of sustained inflation is sustained inflation is defined as inflating pressures more than 5 seconds Up to 3 such inflations, up to 15 seconds each, up to 20 to 30 centimeter of water. Now, preclinical studies have shown that it leads to a rapid and homogeneous lung aeration at birth through improved clearance of lung fluid probably. However, a systematic review and meta-analysis was conducted involving RCTs in preterms, which studied the effect of sustained inflation versus standard resuscitation at birth. They included 9 studies, including the largest RCT, namely the SAIL trial, or the sustained aeration of infant lung trial, and they found no difference for in-hospital mortality, and sustained inflation actually increased the risk of death within the first 2 days. The SAIL trial also was stopped prematurely due for the same reason of an increased risk of mortality which was found in the first 2 days, and also found no difference in long-term outcomes as evidenced by death or incidence of bronchopulmonary dysplasia at 36 weeks PMA. And volume targeted resuscitation. This follows from the principle that ventilator-induced lung injury, the cascade, can be triggered right from those harmful initial inflations at birth. And hence, the use of a respiratory function monitor was suggested so that we could measure the volumes and pressures being delivered by using pressure and flow meters, which, as we can see here, are connected at the interface between the endotracheal tube at the infant side and the pressure generating T-piece resuscitator here. A systematic review and meta-analysis involving 3 RCTs found no differences in the rates of death before discharge with versus without a respiratory function monitor. However, there was a significant reduction for brain injury, a combination of intraventricular hemorrhage and periventricular leukomalacia, which can be explained by the lower fluctuations of the carbon dioxide levels probably when we use an optimal volume strategy. The effect of positive end expiratory pressures on the establishment of functional residual capacity was shown by Swathi et al. On their study on preterm rabbit lungs who were intubated and mechanically ventilated at birth. They found that the application of 5 cm of positive end expiratory pressure led to improved air being retained in the lungs at the end of expiration, as we can see here, versus the application of peak inflation pressures alone, where there is negligible gas at end of expiration. What is the right PEEP? Positive end expiratory pressure must be titrated to achieve an optimal lung volume, hence leading to the best ventilation perfusion matching with minimal oxygen requirement. As we can see in this static compliance curve of the lung here, this zone of the ideal PEEP lies between the lower and upper inflection points. In acute respiratory distress syndrome, we titrate the PEEP up until FiO2 requirement falls and then reduce it once the FiO2 is less than 30%. In older infants with BPD, high initial PEEP is required up to 8 to 12 cm of water due to the collapse of their small airways early during expiration due to the fibrotic changes. Oxygenation-guided recruitment. The principle from this, as we can see in this image, is that initially when we start with a collapsed alveolus, there is predominant right to left shunting happening with pulmonary arterial blood not being oxygenated. As we increase the pressure applied and we achieve recruitment of alveoli, there is an optimal ventilation perfusion matching with subsequent distension during inflation. However, further increase in the pressures applied leads to over-distension and compression of the pulmonary alveolar vasculature, resulting actually in increased dead space. However, this makes two assumptions. One, the diffusion interface must be normal, and 2. There must be no extrapulmonary shunting. In order to achieve the best ventilation perfusion matching, we must minimize the total pulmonary vascular resistance, which is a composite of alveolar and extraalveolar vascular resistance. Alveolar vascular resistance is least at lower volumes of the lung owing to lower compression directly, whereas extraalveolar vascular resistance is lowest at higher volumes of the lung owing to the tortuous vessels becoming straight at higher pressures. However, it is the functional residual capacity at which both alveolar and extraalveolar vascular resistance are optimally low enough to lead to the lowest total vascular resistance, hence leading to the best ventilation perfusion matching. What are the tools for the assessment of lung recruitment? Chest X-ray gives us an idea on inflation of the lungs. Adequate inflation typically being defined as the presence of 6 anterior and 8 posterior intercostal spaces. However, it gives us only a static picture. Tracer gas washout technique, respiratory inductive plethysmography, and electrical impedance tomography are experimental methods not available at the bedside. Oxygenation, oxygenation-guided recruitment, whose principle we have seen just in the previous slide, is the most commonly used bedside tool. As recruitment and subsequent stabilization of the lung will lead to adequate gas exchange, partial pressure of arterial carbon dioxide can also be used. Coming to the next broad principle, minimizing volutrauma. We can reduce volutrauma through patient-triggered ventilation and the avoidance of asynchrony, volume-targeted ventilation, and high-frequency ventilation. Asynchrony, the problem. We must understand that the total tidal volume expanding the lung is contributed both by the machine-generated positive pressure as well as patient-generated negative intrapleural pressure, which leads to the total transpulmonary pressure. Inspiratory asynchrony occurs when the machine delivers a peak inflation pressure at a time not coincident with the initiation of the patient's own inspiratory effort, which can lead to an increase in transpulmonary pressure, increased tidal volume delivered, and alveolar overdistension. Whereas expiratory asynchrony, which occurs when the ventilator is delivering a breath while the patient is actually exhaling, leads to increase in thoracic pressures, auto PEEP, increase in intracranial pressure and intraventricular hemorrhage even in preterm neonates, and can offset the spontaneous rhythm. The various modes of invasive mechanical ventilation can be divided into volume controlled and pressure controlled, depending on that limiting variable which controls the gas flow in the lungs. Owing to the large compliance of the ventilator tubings as well as the variable endotracheal tube leak, volume controlled ventilation is not used in neonates. Coming to pressure controlled ventilation, can be divided into synchronized and unsynchronized modes depending on whether or not the ventilator delivered breaths are synchronized with the patient's own spontaneous efforts. Unsynchronized mode is intermittent mandatory ventilation, in which the ventilator delivers breaths at a set rate irrespective of the patient's own efforts. Coming to the synchronized modes, in synchronized intermittent mandatory ventilation, again, the ventilator delivers breaths at a set rate. However, there is an assist window in which it waits for the patient to take a spontaneous breath. If so, the breath is supported. If not, a mechanical breath is delivered. However, patient spontaneous breaths above the set rate remain unsupported, thus achieving only incomplete synchrony. Coming to assist control mode of ventilation, we achieve complete inspiratory synchrony here as every breath of the patient is supported by the ventilator and there is only a backup respiratory rate as a backup in case of apnea. However, there is no expiratory synchrony as we use a fixed inspiratory time owing to time cycling. Coming to pressure support ventilation, where we use flow cycling to switch from inspiration to expiration below a certain threshold of the inspiratory flow, thus achieving both inspiratory as well as expiratory synchrony. However, there is no backup rate as well, thus completely dependent on the patient's own spontaneous efforts. Volume targeted and volume guarantee ventilation, as we shall be seeing in the further slides, are further refinements of pressure controlled ventilation, which can be used with any of these modes. The conventional mode of neonatal ventilation is pressure-controlled, time-cycled, and continuous flow ventilation. This allows us to ventilate despite large endotracheal tube leaks and directly allows us to control inflation pressures and time. The problem, however, is that lungs disease are not static. With time, there is change in compliance, both improvement as well as worsening of compliance can occur, and hence the tidal volume, which is the critical determinant of ventilator induced lung injury delivered, will keep changing with time, even with specified inspiratory pressures. Hence, the rationale for volume targeted ventilation. We set a constant tidal volume, avoiding wide fluctuations. The pressure required to deliver that tidal volume is calculated by a microprocessor. Hence, we avoid overdistension, volutrauma, and hypocapnia, and also helping in auto-weaning, as the pressures with improved compliance are automatically reduced by the ventilator to deliver our set tidal volume. Volume targeted ventilation is a pressure controlled mode in which we target a tidal volume, and the pressures required to deliver that are calculated by a microprocessor. We use the corrected end expiratory tidal volume of the previous breath to calculate the pressure controlled in the current breath. Now, corrected in terms of leak, we use end expiratory rather than end inspiratory tidal volume because the leak during expiration is less than that during inspiration. Only a few ventilators, however, have this leak compensation algorithm, and hence if the leak exceeds 40%, then usually we switch off volume targeting. Now, there are safety mechanisms to limit the increments in pressure and volume between two breaths, that is, a maximum of 3 centimeters of water above the working pressure of the previous breath can be increased. And coming to volume, only up to 130% of target volume increments are allowed by the ventilator. We set a specific target tidal volume and maximum peak inflation pressure, along with the positive end expiratory pressure and inspiratory time, which remains set. The ventilator delivers a breath and measures the end expiratory tidal volume of the previous breath. If this is equal to our target tidal volume, then the pressure delivered remains same as the working pressure, which is that of the previous breath. However, if the measured end expiratory tidal volume exceeds that of our target, then the ventilator reduces the inflation pressure delivered, and vice versa. If it is below our set target tidal volume, the ventilator increases the delivered inflation pressures accordingly. What is volume guarantee ventilation? This is a further refinement of volume targeted ventilation, again based on the principle that it is transpulmonary pressure versus simply the delivered pressure, which actually determines the target tidal volume, as spontaneous breaths of the infant are intermittent and highly variable, and hence simple volume targeting will lead to episodic hyperinflation. Simple volume target ventilation versus volume guarantee ventilation. Simple volume targeted ventilation uses a single control algorithm in which the ventilator uses the working pressure based on the corrected end expiratory tidal volume of the immediately previous breath. Now let's say there is a spontaneous effort here. So a much lower inflation pressure will be required to achieve our set target tidal volume. When this is succeeded, however, by a controlled breath, much lower tidal volumes will end up being delivered as the ventilator senses lower inflation pressures required. However, when this in turn is succeeded by a spontaneous effort again, which is highly variable and unpredictable both in terms of timing as well as magnitude, there will be hyperinflation because the ventilator senses that higher inflation pressures are required to reach the target, as well as this being imposed on the patient generated negative intrapleural pressure, and thus volume targeted ventilation alone, although within the confines of our safety limit of 130% from our target tidal volume, is prone to lead to oscillations in the delivered tidal volume, leading to episodic hyper and hypoinflations to some extent. This can be avoided and fine-tuned by volume guarantee ventilation, which is a refinement of volume target ventilation in which we employ a dual control algorithm. The ventilator first senses whether the breath is an assisted breath or a controlled breath based on the initial negative pressure at the airway pressure, and then uses the working pressure as based on the corrected end expiratory pressure of the previous breath of the same type, be it assisted or controlled, leading to minimal oscillations in a tidal volume delivered. What should be the initial tidal volume setting? It is based on the pathology of the lungs. So typically our baseline tidal volume is 4 to 4.5 ml per kg, which would be required in normal lungs, term or late preterm, as well as in preterm RDS between 1.2 to 2.5 kg. Now preterm RDS with lower weight still and earlier gestational ages will require proportionately higher target tidal volumes owing to the dead space of the flow sensor being that much more significant in comparison with their small lung volumes. In term meconium aspiration syndrome, again, we would require high tidal volume due to a different reason, however, being that of the increased alveolar dead space. And the highest tidal volumes will be required in established severe bronchopulmonary dysplasia, in which there is both greatly increased alveolar as well as anatomical dead space. However, lower respiratory rates will be required due to longer time constant, owing to the increased airway resistance and collapse of the small airways early during expiration. The evidence for volume targeted ventilation versus simple pressure limited ventilation. So according to Klingenberg et al., based on the Cochrane database of systematic review, so they found that there was a significant reduction in the incidence of bronchopulmonary dysplasia at 36 weeks postmenstrual age, grade 3 to 4 IVH, periventricular leukomalacia with or without severe intraventricular hemorrhage, pneumothorax, hypocapnia, as well as the days of mechanical ventilation. Coming to the next strategy to reduce volutrauma, high frequency ventilation. This works on the principle that we deliver extremely low tidal volumes, which are even lesser than the anatomical dead space. So there are two main types of high frequency ventilation, namely high frequency oscillatory ventilation and high frequency jet ventilation. In the former, there is an oscillator at the airway end of the patient which oscillates at high frequency, which varies between 1.5 to 20 Hz, leading to a rate of between 150 to 2500 per minute. And the other type being high frequency jet ventilation, in which the device delivers initially a jet followed by expiration, which is passive. Here, the mean airway pressure is under our manual control and the amplitude of oscillation is altered to achieve our target tidal volume. So animal studies and older trials have shown improved outcomes compared with conventional ventilation. And high frequency jet ventilation is the preferred modality in the presence of air leak. So coming to high frequency ventilation. So this diagram shows us high frequency oscillatory ventilation in which we can see the tracing of pressure versus time. The dotted is that of the HFOV versus the black line is our conventional pressure controlled ventilation. Here we can see that there is an oscillation of pressure at high frequencies leading to delivery of nearly constant alveolar pressure as well as very low tidal volumes which are less than the dead space, thus avoiding pressure and volume swings at the alveolar level. Now, the open lung strategy in high frequency ventilation. The recruitment maneuver is most commonly studied and as well as established in high frequency ventilation. So let's see this here from this diagram of pressure versus time. Starting from collapsed lung at point A. So we gradually increase pressures delivered. Here, the continuous distending pressure or the mean airway pressure, which corresponds to a positive end expiratory pressure, is gradually increased. Now, as we increase, the FiO2 requirement will fall based on our oxygen-guided recruitment, as we have seen earlier. Up until a point B at which the lungs are recruited, the FiO2 begins to fall below and is below less than 30%. At this point, we know that the lungs have been recruited, and this in fact is our opening pressure of the lungs. Once we know what the opening pressure is, we gradually decrease the continuous distending or mean airway pressure until a point C at which again the FiO2 rises above 30%. Now this we identify as the closing pressure of the lungs, again based on our oxygen-guided recruitment. Now once we know what the opening and closing pressures are, we increase the pressure back again rapidly to our opening pressure at which the lungs are recruited. And for a short duration of time, we continue applying these pressures until all alveoli are recruited, following which we drop down the pressures to 2 cm above our closing pressure to stabilize the alveoli in their expanded state. Which will be the optimal continuous distending pressure or mean airway pressure. A systematic review and meta-analysis was performed involving 3,000 participants and 10 randomized controlled trials in elective high-frequency oscillatory ventilation versus conventional ventilation using the newer modalities of volume-targeted and volume-guarantee ventilation in preterm infants, and they found that HFOV was only equally effective as conventional ventilation, and hence remains a rescue modality. And hence the message here is that it is our strategy of the open lung strategy which is more important than the mode of conventional versus high frequency ventilation, as the strategy applies to both. Coming to our third broad principle, reducing oxygen toxicity. Reducing oxygen toxicity. As we have seen earlier, once we use the open lung strategy and reduce Atelectrauma as well as use volume targeting ventilation to reduce Volutrauma, automatically our FiO2 requirement will reduce when we achieve that optimal ventilation perfusion matching, following which we must use our target saturations to accordingly titrate down our FiO2s. Now this is usually being done manually, right? So automated closed loop oxygen delivery has the automatic adjustment of FiO2 based on our saturations of oxygen. As we see here, this is our manual method in which we manually reduce the FiO2 as our saturations improve to maintain it in that target range. However, in automated closed loop, the ventilator does this on its own using a closed loop FiO2 control algorithm. So a systematic review actually showed that there was an increased time in the target SpO2 range using this automated closed loop delivery system. However, long-term outcomes were not studied. Now, antioxidants have been proposed owing to the premature antioxidant system of preterms, including vitamin A, pentoxyphyllin, as well as superoxide dismutase, as well as anti-inflammatory azithromycin has been proposed. However, more studies are required before we can recommend their usage. Optimizing ventilator support.
Now, once mechanical ventilation is deemed necessary, and we have initiated it according to the broad principles that we have discussed up until now, so we must choose the appropriate strategy based on the pathophysiology, following which we must continually assess the patient's clinical response in conjunction with the pulmonary graphics. The blood gas must be performed 30 to 60 minutes after setting, which is merely to refute our clinical findings. We have various tools in evaluating patient response which must be used in conjunction with each other rather than in isolation, the most important of which being clinical. Firstly, observe for optimal synchrony. That is, each spontaneous breath of the neonate must be adequately supported. Secondly, observe for tachypnea and air hunger, which signal that the neonate is trying to compensate in order to achieve an adequate minute ventilation, and hence the baby is under-supported. So we have to increase our set target tidal volume in case of volume-targeted ventilation, or our peak inflation pressure in case of conventional pressure control ventilation. Thirdly, observe for retractions, which signal the presence of an inadequate functional residual capacity, hence leading to an increased work of breathing. This can be mitigated by increasing our positive end expiratory pressure. These clinical findings must be corroborated with the ventilator graphics, as we will be discussing in the subsequent slides. The chest X-ray also gives us an idea regarding the functional residual capacity of the lungs. Optimal inflation is signaled by the visibility of 6 anterior and 8 posterior intercostal spaces, although the chest X-ray gives us only a static picture. The blood gas, as we have discussed earlier, must be performed 30 to 60 minutes after the initial setting. Our target range for partial pressure of carbon dioxide must be between 40 to 50 millimeters of mercury. That is, we use permissive hypercarbia as a strategy in gentle ventilation. Both hypo as well as hypercarbia outside this range have been shown to be detrimental to the preterm brain by causing changes in the cerebral circulation. Capnography, although a valuable tool, is limited by the presence of leak, which is quite common in neonates given the use of uncuffed tubes, as well as by its non-availability. Next, coming to ventilator graphics in optimizing ventilator support.
There are two types of ventilator graphics, namely loops and scalars. Now, loops are against two ventilator variables other than time, while scalar is one variable plotted against time. So we have flow volume loops, pressure volume loops, and flow pressure loops. So in flow volume loop, as we can see here, initially we start with zero flow, and during inspiration the flow gradually increases until mid-inspiration, where the peak inspiratory flow rate is achieved, following which there is a decrement in flow. And during expiration, the peak expiratory flow rate is actually achieved during the initial half of expiration and further reduces to zero again. Now coming to our pressure volume loop, as we have seen previously during when we studied the Laplace law as well. So we initially start at the positive end expiratory pressure here, And again, there is an increment in pressure during inspiration, and then we reach the apex here, and then during expiration, the pressures decrease. And owing to the law of Laplace, at any given pressure, the volume during expiration is greater than that during inspiration. Now this line here actually gives us the overall slope of the lung compliance. And this is affected by both increases in the positive end expiratory pressure will shift the curve upwards and to the left owing to improvement in compliance, as well as can be seen during surfactant administration. Now coming to scalars in which ventilator variables of flow, volume and pressure are plotted against time. So in this flow time scalar, we can see the effect of optimal time on your ventilation. So here, in which there is a short inspiratory time of Ti, actually our peak inflation pressures will not be achieved. The flow won't remains above zero even at the end of inspiration here. Now in a normal inspiratory as well as expiratory time, we see that the flow is being allowed to drop to zero before we cycle over to expiration, and the PIP is achieved with no plateau. However, when we increase further our long TI or inspiratory time, there is a prolonged plateau leading to potential lung over distension, and which is translated on the flow time scalar as an inspiratory hold. This in turn will affect the expiratory time, leading to short expiratory time, which leads to air trapping and auto PEEP, in which our pressures at end expiration will remain above our positive end expiratory pressure. Let's look at this in more detail. Air trapping or auto PEEP. So this can occur in three situations. One, there is increased expiratory resistance due to, let's say, secretions or bronchospasm, and thus expiration is not complete. Or there is a short expiratory time, or there is early collapse of alveoli due to a low positive end expiratory pressure. So when we see this air trapping or auto PEEP, we must look for these causes and correct them accordingly. How will they translate on our ventilator graphics? In this flow volume loop, we can see air trapping occurring here as the flow does not reach zero even at end expiration. In this pressure time scalar, we see this auto PEEP being depicted as being above the set PEEP at end expiration, and in this flow time scalar, we see that the expiratory flow does not return to the baseline due to air trapping. Coming to overdistension. So on our volume pressure loop, we see this as beaking of the curve owing to our volumes being close to the total lung volume, and further increases in pressure hence do not lead to further increases in lung volume, leading to volutrauma over distension. Now this is typically due to high peak inflation pressure in volume targeted ventilation. This is due to a high set tidal volumes, or could be due to a failure to reduce our peak inflation pressures with improved lung compliance when we are using our conventional pressure controlled ventilation. Air leak. Some amount of air leak is inadvertent in neonates owing to the widespread use of uncuffed endotracheal tubes. Now let's see how this manifests on ventilator graphics. In our flow volume loop here, we see that the expiratory volume fails to reach the inspiratory volume, the magnitude of which is proportional to our air leak, leading to our break in our curve. It can also be seen as an incomplete loop in our volume pressure loop. And the volume time scalar is manifest again by our expiratory volumes, falling short of the delivered inspiratory volumes because there is greater leak during inspiration. And in our flow time scalars, leak is manifest by the presence of flow, which is detected due to the leak even at the end of inspiration. Now, the problem with significant air leaks in using volume targeted ventilation is that it will underestimate the delivered tidal volume when we use expiratory tidal volume, and hence leading to potential for overdistension and hypocapnia, and hence we have to turn off volume targeted ventilation when the leak exceeds say 40%. When we detect significant amount of leak, check the position of the endotracheal tube or the circuit for any disconnection.
In summary, the prevention of ventilator-induced lung injury begins right from the delivery room. The use of non-invasive modalities leads to a significant reduction in ventilator-induced lung injury. The open lung strategy, that is, open the alveoli and keep them open through application of optimal peak inflation pressure and positive end expiratory pressures, has to be used irrespective of the ventilation modality. We must synchronize invasive mechanical breaths with the patient's own spontaneous efforts. Volutrauma being the major driver mechanism of ventilator-induced lung injury, volume-targeted ventilation helps us to achieve minimal fluctuations from our set target tidal volume, despite changes in lung compliance. Once the initial settings are chosen, we must continually assess the patient's clinical response, ventilator graphics, as well as blood gases in order to optimize the ventilator settings. Most importantly, minimize the number of ventilator days. Thank you.